Discover the 2 essential factors you must confirm before diagnosing true resistant hypertension. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, board-certified nephrologist, certified hypertension specialist, internal medicine specialist. See video description for disclosures. A 51-year-old man is evaluated at a routine nephrology visit for persistently elevated blood pressure. Medical history includes Crohn disease status post-ileocolic resection, asthma, obstructive sleep apnea treated with nocturnal continuous positive airway pressure, coronary artery disease treated with a drug-eluting stent 2 years ago, and chronic musculoskeletal pain. Medications are lisinopril 40 mg daily, amlodipine 10 mg daily, chlorthalidone 25 mg every morning, aspirin 81 mg daily, budesonide formoterol inhaler twice daily, and acetaminophen as needed. He reports daily marijuana use and at least 5 alcoholic drinks each evening. He does not use non-steroidal anti-inflammatory drugs or sympathomimetics. Seated vital signs are blood pressure 176/98 millimeters of mercury in both arms, pulse 84 per minute, respiratory rate 14 per minute, temperature 36.3 degrees Celsius, oxygen saturation 98% on room air, and body mass index 32 kilograms per square meter. Cardiovascular, pulmonary, abdominal, thyroid, and peripheral vascular examinations are otherwise unremarkable. There are no abdominal bruits and no peripheral edema. Recent laboratory studies show sodium 140 millimoles per liter, potassium 4.1 millimoles per liter, creatinine 1.0 milligrams per deciliter, calcium 9.3 milligrams per deciliter, and fasting glucose 97 milligrams per deciliter. Morning plasma aldosterone is 6 nanograms per deciliter, and plasma renin activity is 0.6 nanograms per milliliter per hour, giving an aldosterone to renin ratio below the screening threshold for primary aldosteronism. A 24-hour urine collection shows sodium excretion 180 millimoles and metanephrines within the reference range. Ambulatory blood pressure monitoring recorded a 24-hour average of 168/90 millimeters of mercury. Pharmacy refill data, pill counts, and serum drug levels confirm adherence. Which of the following statements best characterizes the epidemiologic phenotype represented by this patient after objective exclusion of pseudo-resistance? Option A. He still has only apparent resistant hypertension because abnormal ambulatory monitoring does not change the epidemiologic classification once adherence is objectively confirmed. Option B. He most closely matches the common epidemiology of catecholamine-driven resistant hypertension, which accounts for most confirmed resistant hypertension after adherence testing. Option C. He fits an epidemiologic pattern in which obesity, sleep apnea, and high urinary sodium are usually absent once secondary causes are excluded. Option D. He has true resistant hypertension, a smaller subgroup than apparent resistant hypertension, enriched by obesity, sleep apnea, excess sodium, and alcohol use. The correct answer is option D. He has true resistant hypertension, a smaller subgroup than apparent resistant hypertension, enriched by obesity, sleep apnea, excess sodium, and alcohol use. This patient has true resistant hypertension. Pseudo-resistance has been objectively excluded because ambulatory blood pressure monitoring remained elevated, pharmacy refill data and pill counts confirm adherence, and serum drug levels verify ingestion. After that workup, the phenotype is no longer apparent resistant hypertension but confirmed resistant hypertension. Epidemiologically, confirmed resistant hypertension is a smaller subset of apparent resistant hypertension and is commonly enriched by the same high-burden traits seen here: obesity, obstructive sleep apnea, high sodium intake with 24-hour urine sodium of 180 millimoles, and heavy alcohol use. The normal metanephrines and low aldosterone to renin ratio make the exotic endocrine explanations less likely than the usual resistant hypertension phenotype. The incorrect options fail because they ignore what the STEM already proved. Abnormal ambulatory monitoring absolutely matters. Once out-of-office hypertension is confirmed and non-adherence is excluded, the patient is classified as having true resistant hypertension, not merely apparent resistant hypertension. Catecholamine-driven hypertension is not the common epidemiology here. Pheochromocytoma is uncommon, and this patient has normal urine metanephrines and no classic adrenergic syndrome. It is also incorrect to say obesity, sleep apnea, and excess sodium are usually absent after secondary causes are excluded. In real-world resistant hypertension cohorts, those features are common and often central drivers of persistent hypertension. In summary, the correct answer is the statement identifying true resistant hypertension as the smaller, objectively confirmed subgroup enriched by obesity, sleep apnea, excess sodium, and alcohol use. Primary teaching point: resistant hypertension becomes true. Resistant hypertension only after excluding pseudo-resistance with out-of-office blood pressure confirmation and objective adherence assessment. Secondary teaching point: the common epidemiologic pattern is usually driven by obesity, obstructive sleep apnea, excess dietary sodium and alcohol, not by rare catecholamine excess. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.